Hello, I'm Ralf Blackstone. I'm an anesthesiologist, former emergency physician, current researcher in thermal stress recovery, and director of the Research and Development Bench at Statum Technologies in Clearwater, Florida. This PowerPoint lecture is accompanied by a more complete manuscript, complete with references and available at www.polarbreeze.net under the Technical Information section. The title of this lecture is New Insights into Hyperthermia and Heat Illness, with revelations new from traumatic brain injury research in the last 20 years, especially with special emphasis on brain salvage. This lecture should bring together the classic understanding of heat stroke with newer data from applied physiology and traumatic brain injury research to give you a better understanding of heat illness and its treatment. You'll understand why core temp is not rectal temperature, and the differences between brain temperature and core temperature, and what this really means in severe hypothermic illness. You'll see how the brain cools itself with its own natural cooling mechanisms, and how the overwhelming of these mechanisms causes heat illness and heat stroke. I'll also show how we can augment these natural brain cooling mechanisms to reduce heat illness, and how we can more effectively help prevent heat illness itself. The treatment of heat stroke and heat exhaustion really has not changed since the 1960s. The National Fire Protection Agency Standard 1584 and periodic cooling as practiced in athletics has done much to reduce the incidence of heat exhaustion and heat stroke. But heat stroke deaths continue on the athletic field and in industry, and these continue to make headlines. The Environmental Protection Agency tells us that for every heat stroke death, there are at least 10 with permanent disability recovering from heat stroke. Now, we must understand what goes on in the human brain. The human brain is only 2% of your total body mass, yet the brain receives 20% of all blood and cardiac output from the heart. The brain consumes 20% of all oxygen used in the body and utilizes 25% of all body glucose. Therefore, brain heat production is very highly metabolic and higher in humans than the rest of land animals. It is therefore difficult to cool. Normally, brain temperature is 0.1 to 0.6 degrees centigrade, that's 0.2 to 1.08 Fahrenheit, higher than core body temperature, even as you sit casually in your chair. Brain is highly metabolic and is the most sensitive organ to excessive heat. Let's define some terms first. Hyperthermia is the elevation of temperature above normal, 37 degrees centigrade or 98.6 Fahrenheit. Heat illness is an illness caused by hyperthermia. This ranges from miliaria or prickly heat, which is just an irritating skin rash caused by heat, through heat exhaustion and heat stroke with its altered level of consciousness from confusion to coma, developing shock with large blood pressure drops, rapid weak pulse, nausea, vomiting, incontinence, seizures, loss of sensation, coma, and even death. Now let's look at core temperature measures. How do we measure core temperature? Treatment of hyperthermia has always been based on core body temperature. Notice the convention here, T core, temperature of the core. This is how it's listed in the medical and scientific literature. Yet there is no one core body temperature. The best measures of core body temperature, from the best to the worst, are pulmonary artery temperature, TPA. This is used in surgery and ICUs. Here, a catheter is inserted in the neck or underneath the collarbone, threaded down through the superior vena cava into the heart, through the right heart, up into the pulmonary artery to the lung. This is the point from which all body heat from exercising muscle, gut metabolism, excess heat from the outside, all collects at this one point before any cooling can occur in the heart. Okay. This is a very useful and is the most accurate temperature for core body temperature, but It's only available under sterile conditions with an invasive catheter that risks major bleeding in order to get this temperature. Right behind pulmonary artery temperature is esophageal temperature, TES. This is a temperature gained by putting a thermistor on a catheter, 20 to 26 centimeters, through the mouth, down the esophagus, till it sits right behind the heart. Here, its temperature is very close to pulmonary artery temperature, and is the temperature we use in surgery with unconscious patients and the same in intensive care units. However, it requires swallowing a catheter to get to this position, and in the awake patient, this causes severe gagging and even vomiting. Rectal temperature, T-rec, is an easy temperature. You insert the temperature probe 10 to 16 centimeters into the rectum, but it really has a poor correlation to pulmonary artery temperature, as the gut has its own metabolism and is a somewhat vascularly isolated organ, so that temperature changes here lag behind pulmonary artery temperature rises and falls. The worst, however, is skin temperature, one that Sessler from the Cleveland Clinic simply refers to as a random number generator. Especially in potential heat stroke and severe heat stroke, this can actually move in directions opposite, because in severe heat stroke, you shunt the skin, and the skin can become dry and cool, while your core body temperature and brain temperature rise rapidly. Note, the one temperature I didn't mention, tympanic membrane temperature, I haven't really dealt with yet. But research into traumatic brain injury and concussions now clearly shows that brain temperature is not the same as core temperature. What's going on? In traumatic brain injury, the brain temperature, T-brain, may vary as much as 3 degrees centigrade, that's 5.4 degrees Fahrenheit, from your core body temperature measured as pulmonary artery temperature. This research now shows that similar temperature disparities can occur both in vascular stroke and heat stroke. Heat stroke occurs when the brain can no longer compensate for excessive heat, internally or externally generated. Now, above 40 degrees centigrade or 104 degrees Fahrenheit, malignant brain malfunctions begin. Here, cerebral edema with its altered consciousness from mild confusion to coma may occur. Brain arteries tend to spasm and reduce the blood flow to the brain itself. Drops in blood pressure further limit blood flow to the brain. And these two together disrupt the brain's thermoregulatory mechanisms at the base of the brain, knocking out the brain's ability to compensate for temperature. Brain ischemia develops, much as myocardial ischemia leads to heart attack and leads to permanent brain injury, coma, organ failure, and eventual death. When there is an immediate death in heat stroke, it's almost universally caused by critical cerebral edema, causing the brainstem to push itself out through certain membranes in the skull, cutting off the respiratory center and even causing the heart to arrest. Yet, brain actual damage begins at far lower temperatures. At a temperature as low as 38.1 centigrade or 100.6 Fahrenheit, fluid begins to leak from brain arteries into the interstitial support tissue of the brain. This is brain swelling or cerebral edema. If you've ever had a heat headache, this is the cause of your heat headache. Note, the onset of a heat stroke can be gradual or sudden. Understand that human protein begins to denature, loses its normal biological configuration at about 41 degrees centigrade or 105.8 Fahrenheit, with some denaturation becoming irreversible by 41.3 centigrade or 106.3, just half a degree Fahrenheit more. Yet, it's been well documented that marathon runners have had rectal temperatures recorded as high as 43 degrees centigrade or 109.4 Fahrenheit without any apparent brain damage. Why? How? The answer is this natural cooling mechanism for the brain called selective brain cooling, how the brain cools itself separately from the body. Selective brain cooling is the reason rectal temperature basically has very little importance in severe heat illness. Selective brain cooling has been a controversy in experimental physiology since the 1960s, but has now been pretty much proven by traumatic brain injury and concussion research. Here, the face and scalp sweat is the primary method of cooling the brain. That sounds a little odd, but this is how it works. The veins in the face, getting arterial blood to the skin, it goes through the capillaries and comes out through the veins and then returns down the surface of the face before it returns into the superior vena cava and the heart. Normally, this venous blood flow stays on the outside of the skin, but once you get hypothermic, this blood flow reverses, bringing sweat-cooled venous blood back into the skull and cooling the brain. Okay, this is one of the mechanisms for cooling the base of the brain. The normal venous drainage of the scalp is through the emissary veins of the scalp that penetrate through the scalp and skull to the actual brain, and it's the sagittal sinuses. These veins cannot contract once cold is applied to the scalp. Thus, cooling of the scalp cools the brain. This helps brain maintain a temperature lower than arterial blood temperature and the rest of the body. Here's an auxiliary brain cooling mechanism that we understand now is even more important than we thought before. This was originally called thermal hyperthermia, where a hypothermic individual hyperventilates far beyond his or her need for oxygen or elimination of carbon dioxide. This mechanism activates when the pulmonary artery temperature rises above 38.5 centigrade, that's only 101.3, and acts as an accessory heat loss mechanism to cool brain and body. How does this work? Has to do with anatomy. The lung has a surface area approximately 59 times the surface of the entire body. If you're a man 6 feet tall and 170 pounds, you have a body surface area a hair under 2 square meters, or half the size of a ping pong table. Yet you'll have a lung surface area that is 2/3 to 3/4 the size of a tennis court. Given this very large surface area, the entire blood volume of the body circulates through the lungs once every 45 seconds and even a little faster in hard exercise. The blood in these lung capillaries is separated from the inhaled air only by the thickness of the air sac or alveolar wall. This is 0.4 to 1.0 micrometers, or 400 to 1,000 nanometers. And the nanometer is a measure used to size viruses. Remember, COVID-19 virus is 60 to 140 nanometers. Thus, hot blood can easily dump its heat into the exhaled lung, with air exiting the lung, in contrast to blood heat dumped through the skin by using sweat to carry blood heat through millimeters to a centimeter of skin and fat. Thermal hyperthermia is the equivalent in humans to panting seen in lower mammals. This is a form of transpulmonary cooling, an efficient means of removing core body heat in hypothermia and cooling the blood and body from the inside out. And the first organ to receive that cool blood from the lung, you got it, the brain. Thus, the brain is cooled from the inside out. Transpulmonary cooling lowers all blood temperature and helps cool both brain and body from the crown right down to the feet. But if brain temperature does not equal any core temperature measure, how do we know when the brain is being effectively cooled? How do we find brain temperature? If you're a traumatic brain injury researcher and you have your patient at surgery, you bore a hole right through the skull and place your temperature probe on the surface of the brain or deep in the substance of the brain. In fact, this is how brain temperature was established, as being higher than core body temperature. Not very useful in the field when you're trying to treat someone with heat illness. So what do? Now we know eardrum temperature is how we get an idea of brain temperature. So how do we treat and reverse brain swelling and restore brain blood flow? In the treatment of heat illness, hypothermia will cause the brain to swell, cause it to get ischemic, and thereby it cooks its neurons. What has been established? Greater time at high brain temperature equals greater brain damage, but the faster lowering of brain temperature equals greater brain preservation and salvage. Standard treatment of heat illness heretofore has been gold standard cold water immersion, CWI. This has been the standard treatment for heat illness for decades. But as it's usually implemented in CWI, the victim's body is immersed in ice water, but not the head or face. These remain untreated. This causes a delay in bringing down brain temperature and brain damage worsens. So I propose changes to standard treatment. 2, in fact. Number 1, cool the scalp and face immediately and continuously in cold water immersion. Simply grab a paper cup, fill it with the ice bath water, and pour it over the face and scalp repeatedly. This uses the selective brain cooling mechanisms to rapidly lower brain temperature as the body cools in the ice bath. Do this as rapidly as possible, even starting with just a bottle of cold water if that's all you have. Human and animal research now supports, and I quote, "Rapid lowering of brain temperature is the most potent neuroprotectant known in traumatic brain injury and heat illness." I propose a change number 2 to standard treatment. If available, have the victim also breathe a cold airstream through the lung, transpulmonary cooling. Remember, lung has 59 times the surface area of that body immersed in the cold water immersion tank. By cooling through the lung, you rapidly cool the whole blood volume every 45 seconds as the blood passes through the lung. And such cool blood is then pumped directly to the brain, cooling it. Now, what are the effects of brain cooling in heat illness? Well, that massive brain swelling, cerebral edema, stops and begins to recede as the interstitial brain water is reabsorbed. The brain artery spasm relaxes and restores blood flow to the brain, washing out all accumulated heat and toxic metabolic byproducts. As well, it restores oxygenation to the brain. These help reverse brain ischemia and improves brain function. As well, intracranial pressure begins to drop as cerebral edema recedes, and this improves brain function as circulation improves also. Now, implementing these brain cooling improvements. Change number 1, when you got your victim in the ice bath, use any large volume cup or other container to pour ice water over the face and head, augmenting selective brain cooling mechanisms. And 2, augment the transpulmonary cooling mechanisms with a microenvironmental air chiller, which is a device that can work outside in outside heat and still produce an airstream 60 to 69 degrees Fahrenheit in all hot outside environments. If the heat illness is not severe and you can get this victim into an air-conditioned room, do as we did in high school with simply placing your face before the air conditioning vent in a closed cold room and have him suck cold air until he feels better. Usually confusion and headaches begin to recede within 5 to 10 minutes and you feel much better. There's 2 products that my company produces, the Polair B300 and the Polar Breeze Mark I. The Polar Breeze Mark I is a refrigerant-based cooling unit. The Polair B300 is a crushed ice-based cooling unit. Both of these produce an airstream in the 60 to 69 degree Fahrenheit range, sometimes even colder. While these improvements will greatly aid brain salvage in heat stroke, it is the purpose of every health and safety officer, athletic trainer, or training sergeant to never let heat illness get to heat exhaustion and heat stroke. How? The answer really is effective periodic cooling and vigilance watching your charges. Periodic cooling in hot environments helps prevent overheating and severe heat illness all the way to heat stroke. This is thermal rehabilitation as used in firefighting, percooling as used in athletics, and cool down breaks used both in the industry and the military. These help lower body temperature and brain temperature by allowing giving up of heat via the natural sweat and pulmonary cooling mechanisms. Don't forget rehydration, because to keep these mechanisms operating, you must replace electrolytes and water lost in sweat. But what works well in heat stroke works well in periodic cooling also. Microenvironmental air chilling units provide a cold airstream to the face, scalp, and lungs for selective brain cooling and transpulmonary cooling by the simple use of a hood. Think of the hood as putting the face against the air conditioning vent. And it not only cools the face and scalp, but breathe it in and cool the lungs as well, by all possible active ways. Now I want to show you a video from the thermal rehabilitation of the World Finals Firefighting.
I love it. It cools you down quicker, like cuts your regular recovery time in like a third. It normally takes me 15, 20 minutes to get cooled off. It's about 5. I feel like I can get up and go again now.
Thus you can see how just 5 minutes of cooling inside a Polar Breeze Mac hood has restored this firefighter from his thermal hyperthermia back down to being able to talk by 4.5 minutes, and by 5.5 minutes, he says he's ready to do it all again instead of the normal 15 to 20 minutes it takes for these guys just to be ready to walk it off. I have done research at the Florida State Fire College with firefighter instructors in burn house training, where these instructors will go into a burn house with fire running in it so that it's 1,500 degrees at the 6-foot level, so they crawl around on the floor at a cool 250 to 300 degrees in Nomex suits and bunker gear so that they can't evaporate any of the sweat on their body. These people have come into our thermal rehab tent with temperatures from just 101 up to over 104 and having severe symptoms of heat exhaustion. What we've noted that in the Polar Breeze hood, that the tympanic membrane temperature, the eardrum temperature, drops approximately 1 degree centigrade every 5 minutes in the hood. That's about 1 degree Fahrenheit every 2 to 3 minutes. And that full thermal recovery usually requires less than 10 minutes. Interestingly, as these instructors got near to an eardrum temperature of 37 degrees or 98.6, they'd start to note a feeling of chill. This became a very important monitor for when thermal recovery was complete. Thus, a MAC unit used for periodic cooling helps prevent heat headaches, nausea, and severe exhaustion, as was experienced by all of these firefighter instructors. Regular periodic cooling with a MAC unit also helps prevent serious heat illness if combined with regular hydration. So I'm going to quickly recap all these points. There's quite a bit here. So brain temperature is the single most important temperature in heat stroke and heat exhaustion. Brain temperature can vary 2 to 4 degrees centigrade, that's 3.6 to 7.2 degrees Fahrenheit, from your core temperature measured as pulmonary artery temperature. This is from Kiotkin. Rectal temperature correlates poorly with core temperature and rarely correlates with brain temperature. But eardrum temperature, tympanic membrane, while not brain temperature, tracks with brain temperature changes both in temperature and time. Therefore, eardrum temperature is currently the best approximation of brain temperature that we have and is used in non-invasive traumatic brain injury studies. At a core temperature of only 38.1 centigrade or 100.6 Fahrenheit, brain arteries begin to leak and the brain begins to swell, cerebral edema. Unchecked, this can lead to sudden death and heat stroke. This brain swelling is the cause of your heat headaches when exercising. As brain temperature rises, vascular spasm and an increasing intracranial pressure from brain swelling restricts blood flow to the brain. This causes brain ischemia and that brain damage. Cerebral edema proportionally inhibits natural brain cooling mechanisms by a pressure gradient through the emissary veins of the skull. And brain hyperthermia combined with dehydration worsens brain ischemia and shortens the time to permanent brain damage. But brain compensates with selective brain cooling mechanisms to control brain temperature. These are the face and scalp sweating, which bring cooled blood from the face and scalp back into the brain, cooling the base of the brain and its temperature control mechanisms, as well as the surface of the brain. Here, neither of these veins can vasoconstrict, so cold exposure does not shut down the blood flow of cold blood into the brain. And thermal hyperpnea, a transpulmonary cooling mechanism, is adjunctive, begins operating at 38.5 centigrade, but with the lung at 59 times the body's surface area and only a 400 nanometer separation from blood from outside air. The rapid dumping of blood heat into exhaled air cools the body from the inside out. And of course, that first organ to receive this cool blood from the lung is brain. Once compensatory brain mechanisms fail and heat stroke symptoms occur, brain swelling, vascular spasm, brain ischemia, and brain damage or death may progress rapidly. But rapid cooling of the brain rapidly reduces brain swelling, releases blood vessels from spasm, stops brain ischemia, and its associated damage. I'm going to quote Dietrich and his research associates in 2009. Rapid brain cooling is the most potent neuroprotectant known. And per Schock and his research associates in 2015, time to brain cooling is directly proportional to permanent brain damage. The longer the time, the greater the damage. The shorter the time, the less the damage. Cold water immersion are still current gold standard for heat stroke care, but you need to add selective brain cooling mechanisms, pouring ice bath water over the head and face, and augment transpulmonary cooling through the lung to increase brain cooling rapidity by cooling the bloodstream and the brain from the inside out. Periodic cooling of the overheated, any breathable cold airstream in the 65°F range will work. And don't forget the microenvironmental air chillers, which can be on site, both the crushed ice-based Polair B300 and the refrigerant-based Polar Breeze Mark I. This reduces or relieves heat headaches, nausea, and heat-induced fatigue. And for those still doubtful, proof of what I've been saying comes from therapeutic hypothermia, cancer treatment since the turn of the 20th century. It even received the Nobel Prize for Medicine in 1920. This is a treatment where the patient is placed under a general anesthetic and then is heated to high body temperature, as cancer cells are not as robust as normal cells and die more easily in the heat. This is frequently now combined with chemotherapy and radiation to increase cancer cell death. If you're subjected to therapeutic hyperthermia in the United States, you're going to be warmed up to 109°F for an hour, sometimes more. And if you're in Europe, they'll go up to 113°F. Yet, no brain damage occurs. The why? The head and face are sprayed continuously with cold water to keep the head cool. Selective brain cooling. This presentation has been a shortened synopsis of my paper, New Insights into Hypothermia and Heat Illness, Brain Salvage, available on the Polar Breeze website at www.polarbreeze.net under the Technical Information section, or by emailing me, ralf@polarbreeze.net. The full text and references are available in this manuscript on the website. I welcome any questions or comments you may have at the above email address. Thank you for your time. I appreciate your attention. Have a good day.